Welcome back. If you are a mental health professional, a social worker, or a counselor working in addiction services, you know that the substance use evaluation is the cornerstone of treatment. A poorly written evaluation is just paperwork. It sits in a file. A well-written evaluation is a tool. It advocates for your client. It justifies coverage with payers. It satisfies legal and regulatory requirements. And most importantly, it helps match the person with the right intensity of care. Not too little and not too much. In this training, we are going beyond the basics. You will see how to gather essential data, how to use the 6 dimensions in the ASAM Criteria, 4th edition, and how to move across the updated continuum of care, from outpatient services through the most intensive inpatient levels. By the end of this video, you will have a clear blueprint for writing evaluations that are clinically sound, person-centered, and aligned with the 4th edition. Before you can make any level of care recommendation, you have to understand the person in front of you. The first phase is data gathering. You begin with basic demographics and the referral context. Who sent them and why? Is this a court-ordered evaluation, an employer referral, a medical provider, or a self-referral? That context tells you a lot about external pressure, motivation, and potential consequences. Next is a detailed substance use pattern for each substance. Be extremely specific. For every substance, document the Big 5. First use. When did use start? Frequency. How often are they using now? Amount. Exactly how much per occasion? Route. Smoking, oral, intranasal, IV? Last use. This is critical for assessing acute intoxication and withdrawal risk. Then remember, substance use does not occur in isolation. You need a full biopsychosocial picture and person-centered information. What is their living situation? Any legal charges or child welfare involvement? What are their medical conditions? Pain, pregnancy, cardiovascular issues? What are their mental health symptoms, trauma history, strengths, and treatment preferences? If it is not documented, it is very hard to defend in court, with payers, or in multidisciplinary teams. Once you have the data, the question is, what does it mean for safety, functioning, and treatment needs? The ASAM Criteria, 4th edition, use a multidimensional assessment, 6 dimensions, to organize your thinking and support clinical decisions. While wording is updated in the 4th edition, the core ideas remain familiar. In practical clinical language, Dimension 1, acute intoxication and withdrawal. How intoxicated or sedated are they now, and what are the current or imminent withdrawal risks? Dimension 2, biomedical factors. What medical conditions, pregnancy, pain, or physical limitations affect risk and care needs? Dimension 3, emotional, behavioral, and cognitive factors. What mental health symptoms, suicidality, behavioral instability, or cognitive impairments are present? Dimension 4, treatment engagement and recovery management. How engaged are they in care, and what supports or barriers exist to participating in and sustaining treatment? Dimension 5, risk for return to use or continued use. Given their history, skills, and environment, how likely are they to continue or return to substance use without the right level of support? Dimension 6, person-centered considerations. What personal characteristics, preferences, cultural factors, learning style, cognitive abilities, and practical circumstances must be considered to match services effectively? For each dimension, you identify the key issues and rate the level of risk or severity. Taken together, those 6-dimension ratings guide you toward the most appropriate level of care in the 4th edition continuum. This is the core of your evaluation, matching the person to the least intensive but still safe and effective level of care. The ASAM Criteria, 4th edition, organizes services into 4 main treatment levels, with decimal points indicating different intensities and settings. Level 1, outpatient and long-term remission monitoring. Level 1 includes traditional outpatient services, individual or group counseling, typically fewer than 9 hours per week for adults, as well as long-term remission monitoring for people who are stable but still benefit from structured follow-up and support. These are appropriate when the person's risks in the dimensions can be safely managed without intensive structure and home or community environments are reasonably stable. Level 2, Intensive and high-intensity outpatient. When risks in dimension 1, 3, or 5 increase, or functioning is more impaired, but 24-hour care is not yet necessary, you move up to level 2. This includes intensive outpatient, structured services multiple days per week, totaling around 9 or more hours weekly for adults. High-intensity outpatient, partial hospitalization type services where care is delivered for a large portion of the day, several days per week, while the person still returns home at night. These services provide a stronger therapeutic dose, frequent monitoring, and skill building without full residential placement. Level 3, residential and inpatient services. When the person cannot remain safe or stable in their current living environment or cannot engage in treatment without a 24-hour setting, you step into Level 3. Level 3.1, clinically managed low intensity. Residential, a 24-hour, structured, supportive living environment with a minimum set of professionally directed services weekly, often similar to a recovery residence or therapeutic community with embedded clinical services. Level 3.5, clinically managed high intensity. Residential, a more intensive residential setting with 24-hour support and robust clinical programming for people with significant functional impairment and high risk for continued use, often with co-occurring mental health needs. Level 3.7, medically monitored inpatient services, a 24-hour facility with on-site medical monitoring and nursing care for individuals with more complex biomedical or psychiatric conditions, but who do not yet require the full hospital-level management of Level 4. Here, the person's environment is fully structured, and you can deliver frequent interventions while monitoring safety and stability around the clock. Level 4, medically managed intensive inpatient. At the top of the 4th edition continuum is Level 4. This is delivered in acute care general hospitals or psychiatric hospitals. It provides 24-hour nursing care with daily physician management and is designed for individuals with severe, unstable biomedical or psychiatric conditions where any delay in care could be life-threatening. Medically managed withdrawal management, what many call detox for the most severe and complicated withdrawal syndromes, is provided at this level when needed. Level 4 is reserved for cases where the combined risks across dimensions, especially dimensions 1, 2, and 3, demand the highest level of medical oversight. Across all these levels, the 4th edition also describes enhanced services. For example, services with enhanced biomedical or co-occurring capability to better match people with complex needs. Even if you do not name every suffix in your report, your narrative should make clear why a person needs more or less biomedical and mental health support. Knowing the levels is not enough. Your recommendation has to show the logic that connects the 6 dimensions to a specific level of care. Instead of simply writing, "I recommend Level 2, aim for something like, given the person's moderate impairment in daily functioning, history of return to use following brief outpatient care, and limited but stable biomedical issues, traditional outpatient services are unlikely to provide sufficient structure. However, the person does not require 24-hour supervision or medically monitored inpatient services, as acute withdrawal and biomedical risks can be safely managed in an ambulatory setting. Their living environment is stable and supportive. Therefore, a Level 2 high-intensity outpatient program is the least intensive yet safe and effective level of care. In other words, you explicitly rule out lower and higher levels using the dimensions. That is what supports authorization, interdisciplinary agreement, and truly person-centered care in the 4th edition framework. Writing a substance use evaluation under the ASAM Criteria, 4th edition, means more than checking boxes. It means understanding risks across dimensions, considering the whole person, and matching them to the least intensive, safe, and effective level of care. If you feel like you need more hands-on training on providing court-mandated evaluations or classes, we can help. For more resources, mentorship, or certification training, contact the Diversion Center at 404-503-8069 or visit thediversioncenter.com. We are here to help you become the most effective court-approved provider you can be. Thanks for watching.